move ahead. I was introducing myself as Professor Tony Oyana. I'm here to help and facilitate this session. I hand back this to the Honorable Minister Jane Ruth Aceng. Please go ahead.
Thank you very much, Professor Tony. Unfortunately, we missed the introductions, but we shall move ahead. And I'll give an overview for this session. I hope everyone can hear me.
Yes, Honorable.
So as I mentioned earlier, this is an inter-Africa Health Ministers discussion. The United Nations Sustainable Development Goals and Political Declaration for the UN High-Level Meeting on Universal Health Coverage outlined an ambitious plan to provide access to quality, affordable health care for all by 2030. Now, less than a decade away from that target date, the world is facing unexpected challenges that are making this bold vision more difficult to achieve. The COVID-19 pandemic has exacerbated burdens on health systems around the world and created new hurdles on the path to achieving universal health coverage. In Africa, the pandemic is threatening progress that has already been made towards these global health goals. And governments are seeking new solutions. The private sector has an important role to play in helping countries across Africa get back on track to reach the Sustainable Development Goals and meet national universal health coverage goals. Initiatives such as the SDG Partnership Platform in Kenya that convene all stakeholders involved in the health ecosystem are a strong foundation for public-private partnerships and multi-sectoral collaboration. By leveraging the unique expertise and strength of each sector, public-private partnerships can be a more efficient and effective means to finance care, launch and operate new healthcare facilities, and improve the delivery of innovative diagnostics, treatments, and services, ultimately improving patient lives. In March 2021, Roche launched the FutureProofing Healthcare Africa Sustainability Index, which highlighted the financial, political, and socio-economic conditions faced by many African nations as they strive for truly sustainable healthcare systems and underscored the necessity of information and data gathering. The roundtable discussion in this meeting today will build on the solutions proposed by the panel of experts who helped analyze and launch the FutureProofing Index to consider what partnerships models can be used to uplift the health sector across Africa and accelerate progress on universal health coverage goals. Now, I am sure that many of you in your countries, including those that are specifically in Uganda, you already know the challenges we are facing with the COVID-19 pandemic and what we can do to uplift the health sector and accelerate progress towards universal health coverage goals. So with that background, I will now open up for discussions, and you're free to put up your hand using the platform that you have. I'll be able to see your hand and request you to speak and respond towards some of these issues. So it is now open. Professor Tony Oyana, I request that you take us through the objectives of the meeting. Over to you.
Thank you so much, Honorable Minister of Health, Dr. Jane Ruth Aceng. There are two session objectives. The first goal for this session is to discuss health in Africa, covering leadership, governance, service delivery, health workforce, health information systems, access to essential medicines, and health financing. The second goal is to discuss successes achieved and challenges faced during the Africa's COVID-19 response. Those are the two goals we hope to accomplish during this conversation. Thank you, Honorable Minister, back to you.
Thank you very much, Professor Tony. That was very clear, the objectives that have been given to us. I know members are now ready, and if I can go straight to the participants list, you're free to express your willingness to speak by putting up your hand so that I don't have to ambush you if you're ready. Does somebody want to take us through? Somebody wants to set the pace?
Yes, Honorable Minister, I would like to quickly also add that responding to health challenges requires serious inter-sector action at the global, national, regional, and local levels. Many local governments around the world are already engaged in inter-sector action, and many individual experiences have been documented, but nevertheless, there has been little systematic, there doesn't seem to be a lot that has been achieved at this level. And when it comes to the coming of the COVID-19, it seemed to dull greatly all the achievements, and it puts the whole world into a great need to sanction intersectoral action so that we may register more gains and improve the health of the people of the world. I think for now, Honorable Minister, I would stop at that.
Thank you very much, Professor Ibingira, for that great introduction. I see Dr. Musenero is ready to say something. Honorable Monica Musenero, you never got opportunity to introduce yourself because we had challenges with the volume. I'll give you opportunity to introduce yourself so that the people who are checked in online can get to know you. Over to you.
Thank you very much, Honorable Cheng, and thank you, the Honorable Ministers from other countries and all participants in this session. Dr. Monica Musenero, I am the incoming Minister for Science, Technology, and Innovation in Uganda, but technically I'm an epidemiologist specializing in strategies for disease control. Honorable Minister, I would like to make a submission, and this submission goes beyond the COVID, but looking at, especially in the context of universal health coverage, there are two broad aspects of health that we must look at in order for us to achieve those goals. The first is the category of community. It is impossible to achieve universal health coverage when you have too many people falling sick, because it will become too expensive if every individual has to go. So primary health care, health communication, and putting up primary preventive measures are things that should be prioritized if we are going to achieve universal health coverage. Otherwise, when you have so many people needing a lot of care, it becomes so expensive, the resources are so scattered that it becomes very difficult. And this is evident in COVID. Even countries that were highly resourced, when it came to COVID, the health system became choked. So that is one of the issues. And many countries in Africa that were able to deploy community interventions, epidemiological surveillance, communication and mobilization of communities, they were able to limit and protect the healthcare system. The second aspect that I would like to talk about is if we're going to achieve universal health coverage, it needs to be affordable. And just like now, I know, Honorable Minister, you'd love to test every Ugandan, but you cannot afford the price of these tests. And so African countries have sat on the sidelines expecting these things to come from outside. We saw China was able to put up a hospital in a minute, just like in 1 week, because they had all the resources. So universal health coverage will go side by side with the development of local science that makes the tools that we need to use for healthcare cheap, available, and accessible. I'll limit my presentation to that for now.
Thank you very much, Honorable Monica. I hope we are still online and we can be heard. And Honorable Monica has brought in the aspect of community interventions and other innovations that should be made available. We are still holding this discussion and we are looking at universal health coverage. And many of you know that with the pandemic, most of the gains that we have made, maybe not most, I should use the word some of the gains that we have made over the years in moving towards universal health coverage will definitely be affected by the current COVID pandemic. And yet we are all looking for ways to ensure that our populations access services, quality services that they so much desire without leaving anyone behind. We are all struggling to remain alive. And as you know, it is not easy to access vaccines, which would enable us to open up our economies and also have adequate resources to address some of those challenges. So as we still continue with our discussions, Honorable Minister from Zimbabwe, why don't you share with us some of the experiences you have had in Zimbabwe on how you are coping with the challenges of personal protective equipment in this era of COVID, but also ensuring that you have enough resources to handle other essential services that are required because the population is still sick. Most of the diseases we used to treat have not gone away. The specialized surgical services that we need to give to the population is still what we should be doing. Share with us just what you've been doing in Zimbabwe towards this effect.
Thank you, Honorable Minister. Warm greetings from Zimbabwe, from my President, His Excellency, Dr. Emerson Dambudzo Mnangagwa, and the Vice President, I represent the retired General, CGDN Chiwenga, and also I would want to say, honorable ministers, so allow me to express my gratitude to the host, yourself, Honorable Dr. Ruth Acheng, for inviting us to address this Regional World Health Summit meeting, colleague ministers of health and invited delegates. The SARS-CoV-19 pandemic has been with us for over a year now, and our health systems have faced a litmus test on the state of preparedness and resilience to manage the scourge of this virus. Early on the outbreak of the COVID-19 pandemic, we were all faced with inadequacy and scarcity of personal protective equipment, which included face masks, donning gowns, gloves, face shields, etc. The frontline health workers had to have adequate personal protective clothing to be able to handle the COVID-19 patients. Innovations and partnerships, both public and private, saw most of our systems managing to avail much of the needed PPEs to the frontline health workers. The second major challenge was on the service provision side. We faced the unavailability of ventilators and inadequacy of oxygen supply. Whilst Europe and the Americas were in the deep end of the crisis, we were going into a panic mode if we were to face the same. Fortunately, if I may say, the pandemic has not ravaged the African region as elsewhere, but we are not out of the woods as yet. India has recently suffered a deadly third wave, and we need to be more proactive. We need stronger partnerships on local solutions to the development of life-saving, affordable, and accessible equipment for our health systems. The tertiary institutions and industry need to foster partnerships that see the production of medical equipment in Africa, as we had to do with PPE. Biomedical sciences, engineering technology needs to be supported locally for our systems to be better providers of health care. Information, education, and communication is vital for the general population to be made aware of how to conduct themselves during this pandemic, such as COVID-19. Masking up, social distancing, regular hand washing, and sanitization have become a new normal to contend with. Formal and informal businesses have had to adjust on conduct and worker safety through testing of their staff and provision of the required PPEs and sanitizers. Our economies have gone through various levels of lockdowns as measures to contain the spread of the coronavirus. The effects, both business and livelihoods due to the lockdowns, has been devastating, and a new work culture has been adapted as means to adjust to the new normal. We have seen a growing use of electronic systems and a work culture. Telemedicine needs to be strengthened to reduce the interface of patients and medical staff. We need to develop software solutions that allow the virtual hospital concept to prosper. Ideal frameworks that enable faster access to medical support need to be encouraged. As we step up the vaccination campaign to achieve herd immunity, we need to harness local production capacity to bolster the COVAX facility that has been affected by increasing COVID-19 challenge in India. We need more vaccine options on the table, but we need to create the options for ourselves. Let's identify our own institutions in Africa that we can support to spearhead vaccine development and production if we are to succeed through COVID-19 and other pandemics that will come in the future. The establishment of the African Medicines Agency is a bold step in the right direction and towards sustainability and pharmaceutical sovereignty. Non-communicable diseases need to be profiled more, as they have been the leading cause of death under this COVID era in our region. Let us have countries looking closer on how these conditions are being supported within their own health systems and put measures that improve on the access to care and assistive devices and commodities. Health and well-being is not just a concept, but be action centered across the life cycle and in the service provision within our health systems. I call upon a stronger and rigorous approach to managing non-communicable disease in the African region. Universal health coverage is a goal every nation intends to achieve. Let us define and fully fund essential healthcare benefit packages that cater for the health needs of everyone as and when they have need them without suffering financial impoverishment. Global security due to the impact of COVID-19 requires strong collaboration between and among its nations. The new variants sparking new waves of COVID infections are casting longer notions of protracted periods we have to live with them. We need to be more alert to internal conflicts likely to stem from the most affected and vulnerable groups in our society. We need to be proactive to provide social safety nets to these groups, such as women and children, the unemployed, the urban poor, migrants, the youth, and the disabled. As the African region, we need to step up collaboration on resource mobilization efforts and opening up of lines of credit to members to support and cushion business from the COVID-19 effects on production and employment. Food supply chains have to be kept running and reduce conflicts among nations to better manage this pandemic. We need to have a harmonized strategy on minimizing conflict internally and externally with a multifaceted socio-economic approach that can bring stability among ourselves. Let me reiterate the need for continued cooperation in the region, both on health matters and other areas that forms key determinants of our. Honorable Minister Ruth Acheng, I'm sure this will suffice for now. Thank you, Honorable. Thank you, Honorable Ministers.
Thank you very much, Honorable Minister from Zimbabwe. That was quite very detailed. You brought out the challenges we met previously and what we need to do as Africa so that we can have Africa solutions. I picked up one of the issues that you talked about, and that was the need to have vaccine options on the table, but also ramp up our
No.
Dr. Honorable Acheng, we're not hearing you.
Honorable
Lost
Minister,
you.
are you on?
The Honorable muted.
Can you hear me now?
Yeah.
Yes, you can.
You can hear me.
Yes, Honorable.
Yes, now we can hear.
Yes, so I'll just go back to where we were. I was saying that less than 1% of the population of Africa is vaccinated compared to 40 to 50% of vaccination in some countries and continents. So Africa is definitely lagging behind. We need to vaccinate our populations if we are going to safely open our economies during this very difficult time of the COVID pandemic. Most of the production of vaccines is not in Africa. And I recall during the opening ceremony, the WHO Director General was very clear that there needs to be mechanisms of technology transfer so Africa can start manufacturing vaccines. But turning to Dr. Monica Musenero, Uganda has been putting in a lot of efforts to begin manufacture of its own vaccines during this time of COVID-19. Would you like to share with us your ideas on how Africa can come together as African countries to address the challenges of vaccine availability and vaccine production, and also what we can do during this time to ensure that we also begin to open up our economies, because definitely we cannot keep our people locked up forever. Honorable Monica, you have the floor.
Okay, thank you, Honorable. As we heard from Hense in the opening ceremony, right from when COVID was threatening Uganda last year, work on tools going beyond just vaccines, because at that time we didn't have capacities and sanitizers. We had some limited capacity, but led by the president, he has been pushing for local production as much as possible of the solutions, at least to increase availability. Also an initiative which assigned to me to make
I don't know what we can do about this network. Honorable Monica, we've lost you. Honorable Monica, we have lost you. Professor Tony, could you help us out there? We've just lost our speaker. Or she's
Yes,
back.
Madam, we are following up the matter technically. I would also like to inform you that we have been joined by the Minister of Equatorial Guinea. When you can, you give him a chance to offer his statement.
Right. Honorable Monica is back on.
She's back on.
Honorable Monica, you have the floor.
Can the Honorable unmute? She's back, but she needs to unmute. Again, she's off. I understand she may be having problems with her network. Honorable, you may maybe give the Honorable Minister from Equatorial Guinea a chance as the network is sorted out for Honorable Monica.
Okay, that was a very unfortunate incident, and Honorable Ministers, Your Excellencies, I do apologize for that. In the meantime, allow me to say a very warm welcome to the Honorable Minister of Health from Equatorial Guinea. I had opportunity to meet you during the opening ceremony, and I must say we are happy that you could come to Uganda and share your thoughts during this World Health Summit. We are discussing the challenges African countries face.
Honorable Internet sabotaged my submission. I don't know if I can have a Honorable Chen.
Yes, Honorable Monica, if you're back on, we'll give you that opportunity. Go right ahead.
Can I continue?
Yes, go Continue, but we are not getting you clearly.
Okay, sorry. Struggling with these issues of technology. So I was saying that we have initiatives concerning vaccines. We have the local manufacture of vaccines locally developed. We started working on 4, 3, 2 have reached animal trials. However, we are also working in a with other people who already have approved vaccines been taken place. The president has approved to the honorable minister, and we're in the process of getting the funds and also getting the partners who provide technical support to make sure that we can manufacture vaccines, both ours locally developed, but also the finishing, is it
it is quite unfortunate. Professor Tony Oyana, I request that you put a call through to Honorable Monica and see if we can sort out the challenges she's having with her internet. She was definitely discussing a very important topic, and that is vaccine development and ramping up production in Africa. Allow me to invite the Honorable Minister of Health from Equatorial Guinea to come out and share his thoughts with us. As Professor Tony, you sort out the issue of Dr. Monica. Honorable Minister, you're most welcome. You have the floor.
Thank you very much. I came mainly to share the experience of Equatorial Guinea and the management of the epidemic. The Honorable Minister who spoke before me mentioned very important the impact of the COVID on the economy. When we had the first wave, we had to practically block everything. People could not walk. People must have the mask. People should not travel because our country is one island and mainland. So all this had very negative impact on the economy apart from the health. We did very well on the health aspects, as I could mention some political and strategic actions of rapid response that got very good results in Equatorial Guinea. The creation of the political commitment with the action of the National Technical Committee for the first fight against the disease. There were two committees, the technical and political committee. And the political committee was actually taking decision based on the recommendation of the technical committee. And despite the crisis, the economic crisis, political commitment is very, very important. And we were lucky that most of our requests, we were not prepared like all other countries, we were not prepared to, but most of our requests, they were delivered by the government. We didn't have respirators, we didn't have trained people. We had to import technology from Cuba, around 77 medical doctors. We keep 3 of our hospitals with all the necessary equipment for emergency. And then the economic aspect, at the beginning, all the positive cases were isolated in hotels. And it became very expensive for the government. All the positive cases were isolated in hotels at the expense of the government, which were not sustainable. So we had to create some practical hospitals in the stadium, improve the stadium in the main country. So we reduce the curve, the epidemiological curve to practical to the control levels to 1.3, 1.6% for 7 months. But then the economic part, how was it dealt with? The government had to identify the most needed people and started, giving some food rations and so on. Many of the enterprises, there was a lot of solidarity for people who have been cut. Those who live in day-to-day small businesses, like bars, like this, they could not do anything. So the government has to invest, and with the solidarity, we started to support them. And then we were very much concerned about the migration. The migration, we were very strict about the migration, about the flights, about the ships. But then we realized that with that, Equatorial Guinea is not a very agricultural country. We depend mainly on the oil. So we import from Cameroon and Gabon. If you close the borders, then what's going to happen? So we release the boats that were actually bringing agricultural products and so on. With the first wave, that was okay, but the government could not continue affording it. So when the second wave came, we were already more or less prepared. Agriculture, there was a commission that was going all over the country to collect whatever agricultural products were produced to bring them to the main town, and these were given free of charge. This is what I'm talking about, political commitment. Now, we talk about production of vaccine. We actually, in the malaria project, if you from Tanzania here, they will know the scenario. Equatorial Guinea has invested about $40 million to help develop a malaria vaccine in the country with the scenario. This is an American university which is actually developing a vaccine. Now, when the COVID came, this is the same structure that we use. The lab that we were using for the development of malaria vaccine is what we were using actually for COVID. And this was a big advantage for us because it is a 35 lab, and then we could actually isolate all type of things, virus and so on and so on. So we were very lucky on that aspect. This was part of the commitment. Now for the vaccine, we already vaccinated about 147,000. I have it here. Yeah, we have vaccinated 148,579 people, and we have got a target of 850,000 population in order to have the 70–80% immunity that we're looking at. Now, these vaccines were donation from China, 340,000 doses. Then our government, just a week ago, we managed to bring in 500,000 doses of vaccine. And I have to add something. When we were talking of equity in vaccine production, distribution, and utilization, the Chinese government with the Sinopharm we had already paid completely cash about $10 million for the 500,000 doses, but to get them to Equatorial Guinea was a big problem. So we had to send our plane to go and carry them. Besides the fact that once the Sinopharm was recognized by WHO, the demand is so high that although we had paid, there were not enough production for them to send us the 500,000 $. So these are the type of difficulties that if we don't have enhanced our own production, whatever, even if we have the money, we would not have the access because we have had such problems. We had an advantage that when the COVID-19 started in China, ignoring that it's going to expand to be a pandemic, our government helped the Chinese government with $2 million. So that's why the Chinese, in response, when this happened, they were able to give us 340,000 doses free of charge. So these are the type of experiences that I want to share. Political commitment, then the impact of the COVID on the economy, national economy, because we had to close the bars, we had to close everything for almost 3 months, and this was very, very, very negative on the economy. And the solidarity is also there. National solidarity is very, very important because when people didn't have something to eat, apart from the government, most of the enterprises, they were actually giving food to people. So it would have been very, very negative for us if we didn't have this type of solidarity, political commitment, and even with the political commitment help us. We didn't have enough doctors to UC intensive care for intensive care. So we had to import doctors for intensive care while we were preparing our own doctors. So this is the experience I wanted to share with you about Equatorial Guinea. Right now, we are down. The infectivity level is about is below 5. It's about 1.30%. So we have really reduced it. We are trying to maintain it. We hope we will be able to do it. We have got already some experience, but it's very costly if we don't mobilize our own resources, our own solidarity, and of course our partners, they should be able to come in and support us now that we need them, because we realize that most of them, they need us, they need our resources, they need our petrol, they need our agriculture. So it's good that when we need them, they should also come in, not only for our resources, but also to support us. Thank you.
Thank you very much, Honorable Minister from Equatorial Guinea, sharing your experience with us. We realize that African countries have nearly the same experience, and you have shared with us some of the challenges you went through to acquire vaccines, very expensively, I must say, in spite of the fact that you first got a donation. And we do hope that your struggle to develop COVID-19 vaccines will come to pass, because you already had a foundation of developing a malaria vaccine. We also want to thank your country for the political commitment and the solidarity from the entire community, knowing that you depend majorly on oil, but also people have to be fed during this time. I see we have been joined by another colleague, Your Excellency Rashid Aman. You're most welcome. We are happy to have you. Dr. Musenero, I do hope you're back online.
Yes, I am back.
Very good. We are happy to have you back. I want to give you opportunity to finish that discussion on vaccines so that we can move to some other topic.
Okay, thank you. As I was saying before I got disconnected, is that right now we have a two-pronged approach or three-pronged approach. Of course, we need vaccines immediately to vaccinate the population, and we're committed to procuring the vaccines. As the Honorable Acheng, you know that in your docket. However, the other one and the President's commitment is to have the country rapidly develop capacity to produce the vaccines, both the fill and finish of approved vaccines, and there are negotiations going on with private sector and other investors, but also to produce our own vaccines. As I mentioned, two of ours, we have two research hubs which have advanced. They have been working over the past 1 year, and we have two candidate vaccines right now going through animal trials. The additional work that we would want is to make sure that there is research support to vaccine usage, because as we know, the vaccines are new, and applying to making sure that we have additional research to better refine the impact of these vaccines on our population, and to provide that information, and that support is additionally being put in place to support the research, the field research, including the communication and the receptiveness of our population towards vaccines. So we also have made a lot of advances in diagnostics, because for an epidemic like this, if you are able to diagnose, you should be able to identify where the virus is and manage to control. And within the next week, we should be putting down our first building, our first factory, that is to produce PCR diagnostics. So that is what we've done, apart from the procurement, which is with the Ministry of Health, but the science support, because we believe that if we are not able to provide, and going further as the Minister of Science, I would really like to, for us on the African continent regionally, to come together and bring our scientists and make a network that ensures that the continent can access and make and utilize the knowledge bases and even the infrastructure we have to make sure that we address a lot of these vital needs and not remain very dependent. Thank you.
Thank you very much.
Honorable Minister,
Yes, please.
I've been advised and guided that Dr. Rashid Aman is representing the Minister of Health Kenya, and he is the Health Chief Administrative Secretary.
Thank you.
Thank you very much. Thank you very much, Dr. Musenero, for sharing with us some of the insights into ramping up production, not only for the vaccines, but also for other necessities during this time of the pandemic. Allow me to welcome Dr. Rashid Aman. We are happy to have you join us in this panel. We have just a very great discussion coming in from Zimbabwe and coming in from Equatorial Guinea. I want to turn to Kenya. Would like you to share with us some of your experience in case management of COVID-19 patients. We know that it is not cheap to treat critically ill patients, but we also know that during the years, Kenya has tried its best to set in place a very robust health insurance services for the population. You could give us some highlights on how you're handling the pandemic, both in the public and the private sector, but also taking care of other disease conditions. Over to you, Dr. Rashid.
Thank you very much, Honorable Minister. It's a pleasure to join you. Of course, we had invited the Cabinet Secretary, but he's tied up with other tasks. So I'm stepping in to, you can hear me, I hope all of you.
Yes, Dr. Rashid, we can hear you. I'm only going to request you to increase the volume of your system. Professor Tony Oyana, mute the other participants, please. Go
We
ahead.
have done that, Honorable.
Let me just get closer to the mic.
Yes.
See if it improves. It is improved now, I hope.
Great, go ahead.
Good, good. So, Honorable Minister, I was thanking you for the opportunity, this very important forum that you have been part of in putting together and organizing and bringing players in from Africa to come and discuss their experiences with the COVID-19 pandemic. It has been truly a testing time for all of us, and I'm sure that every country has a story to tell. I'm happy to share with you some of the things that we have done as Kenya. The pandemic is still raging. We are not yet out of the woods, and therefore we need to continue to tighten our protocols and approaches that we are using to contain the disease. We in Kenya recorded our first case of COVID-19 on the 13th of March, 2020. As of the 27th of this month, we have 182,600 cases, confirmed cases. We have recorded 3,595 deaths so far through this pandemic. This translates to a case fatality rate of about 2%, which I think is what we are seeing in most African countries, somewhat lower than what is seen in some of the other Western and other countries outside of the tropics. We have the disease spread throughout all our 47 counties, with Nairobi remaining an epicenter because of the large population and the range of activities within Nairobi. It has remained as the epicenter. But lately we are seeing a spread, unusual spread of the disease in parts, especially around the western borders with Uganda. I'm sure Uganda is aware of what we are seeing now in Busia, Siaya, Kakamega, Bungoma, and those counties around the border where we know that the Delta variant is really the predominant variant. Most of our cases, the confirmed cases, fortunately turn out to be asymptomatic. We have recorded that from between 90 to 93% of confirmed cases will tend to be asymptomatic. And therefore, we'll have to deal with about 7 to 10% who are symptomatic or pre-symptomatic, who may then progress to requiring clinical management. I think this has been a fortunate thing, and I'm sure most other African countries see the same level of asymptomatic cases as compared to symptomatic cases, because this has made it easier for us to really deal with this pandemic, particularly at the level of case management. Given our limited capacities, given our weak health systems, I think this has been a fortunate thing to see that we have very few symptomatic cases. We have, through this period of time, experienced 3 waves of the virus. We have a wave. The first wave happened in July 2020. Our second wave happened in November 2020. The third wave in March 2021. And some of our modelers are predicting now that, looking back at these waves, that there may be some periodicity to these waves. that every quarter, every 3 months or so, we are likely to have a surge. Actually, right now, we are anticipating that we will be having our 4th wave, probably sometime in mid-July or so, with what we are seeing, the spread of particularly the Delta variant, moving in and sweeping in towards now the eastern side of the country. We are likely to see a wave in July, mid-July this year. We have about 5,592 cases of healthcare workers, our frontline workers. And we recorded about 40 deaths of our valued healthcare workers. In terms of our testing capacity, we have tried to operate at whatever capacity that our resources would be able to take us to. And so far, we have been able to conduct about almost 2 million tests throughout the period of the pandemic. Among these 2 million tests, our overall positivity rate is 9.4%. But of course, we know that positivity rate will change with time depending upon where we are on the curve. In terms of capacity for testing, it still remains, we believe it still remains somewhat of a challenge, because according to the WHO guidelines and the targets that we need to be testing, I think we are below that. And the reason we are below is because of difficulties. Number one, most of these the testing that we do is PCR testing. It requires sophisticated equipment and reagents and costly reagents, which are also in short supply in the global chain, although this has now improved. But through this time, we have been able to build this capacity. We currently have about 48 public sector laboratories that routinely test and report to our national database, including as well as 13 private laboratories. Our gold standard still remains the PCR test, although we are also doing antigen testing now, sometimes at points of entry, just as a screening procedure. But the PCR still remains our gold standard in these laboratories that I have mentioned. In terms of surveillance, we have enhanced surveillance at points of entry with screening and follow-up of visitors from high-risk countries. We conduct a regular risk profile for countries with circulating virus and variants, and equally then adjust our protocols for entry of nationals from these countries. One of the areas that we have really done, I think, quite well is in terms of the surveillance for variants. I think we started fairly early to begin to look at genomic sequencing. Our research institutions have been doing that. Through this effort, we have been able to very quickly determine where the areas of spread of new variants as they come into the country, how they come in, and how they spread in different regions. This is a capacity that we intend to continue to build, because it's very important for us, knowing and seeing the evolution or spread of this virus and the capability to mutate and increase its transmissibility and maybe also its pathogenicity. It is important that we have a very good system of genomic surveillance. The little capacity that we have in this area, we are sharing it with our neighbors. And in fact, we are a WHO designated center for supporting genomic sequencing for our neighboring countries of Tanzania, South Sudan, Burundi, Somalia, and Comoros Islands. And we are currently doing this in about 3 different institutions, national institutions, and 1 international institution. Let me move now, before I move on to vaccination, I would like to talk a little bit about what the moderator pointed out that I need to talk about, is how we have dealt with case management. We realized, and I think the story is the same in all other countries, not only our African countries, but countries all over the world, is that we realized very suddenly that we were confronted by a very, very difficult threat that we may not have been prepared for in terms of our health systems generally being weak at the level of the primary health care and even at the points of referral and the specialized hospitals that we have, limited in number, limited in emergency care and treatment. And these were some of the very early challenges that we anticipated. We tried as much as possible within a devolved health system, because in Kenya, our system is devolved health system. Health is a responsibility of the counties. They get resources to be able to support their activities in health. As a national government, we support them, we help them build their capacity. But it was a bit challenging to try to build up the capacity, particularly of our counties, and to bring it up to a level where we would feel we were prepared to some extent to meet these waves, huge waves that would end up overwhelming our health system. We invested quite a bit of money in the counties. We provided them with resources, and we gave them targets to build capacity immediately, first of all, by building up COVID beds, beds where people with COVID who need hospitalization could be put in. We also urged them to up their ICU capacities and increase the number of beds that they have within their various facilities. This has been a long journey. Some counties have been able to meet those targets. Others are still struggling with it. But in the last particular third wave, which was a great challenge for us, we did experience some level of overwhelming of our facilities, even to the extent of the problem with oxygen. I think Uganda knows very well now, because I know Uganda is going through a similar episode as we went through during our third wave of lack of oxygen, for instance. Of course, coupled with the lack of ICU beds and most critically, lack of human resource who are trained to be able to deal with ICUs and critical care. That is an area that, of course, you cannot fix very quickly. So there will always be a limitation, even if you have enough ICU beds, enough oxygen, you will still have a problem in the area of human resources. These are areas we have identified. These are areas we are now moving forward, trying to bolster, so that when as this pandemic runs its course, or perhaps another pandemic comes in future, that we have a stronger health system where we have improved our HRH, we have improved physical facilities, we have improved access to materials that are required, commodities that are required for health management. So I can say that in the third wave, we were a little bit challenged, but fortunately we were able to ride that wave and come down. But now we are facing the Delta variant and another wave, and the same problems face us, but we are trying to prepare for them as best as we can by facilitating, first of all, in the period between that third wave and now, we have been able to improve on availability of oxygen for our health facilities. We have beefed up the oxygen plants within those facilities. We have piped oxygen into facilities. We have set up tanks, storage tanks in some of these facilities. And we have worked with the private sector, the British Oxygen Company, which is the major producer of oxygen. We have been working very closely with them for them to ramp up their capacity to be able to produce oxygen, including reducing supplies to other non-essential areas, so that these supplies can be channeled towards the needs in health. So I believe that we will see what happens at the end of this upcoming phase of the cycle that we anticipate will happen fairly soon. Now, if I come to the area of vaccination, Honorable Minister and Honorable Ministers, we received our first COVAX consignment of about 1.1 million doses, which immediately went into arms. About 1 million of it went into arms as a first dose. And then we had, as you all recall, that there was the global crisis of access and availability of the COVID vaccine, the one we are using is the AstraZeneca one, manufactured by the Serum Institute of India. The rise of the pandemic and the Delta variant in India, and subsequent ban on export by the Serum Institute of India. That is where our COVAX vaccines were coming from. So we were stuck only with what we received. We quickly ran out of that with the first dose, but we were able to provide at least up to 300,000 cases with the second dose. We also received some donations. We received 100,000 doses from the Indian government very early on. And we recently received another 350,000 donation from Denmark. So with this about under just 1.5 million doses, I think we will just be able to give second dose to most of those 1 million who got it. This is still a very low number. It's still a very low number in relation to our population and in relation to the targets that we have set in terms of the number of people that we want to vaccinate. We had very lofty ideas to vaccinate at least 30 million of Kenyans out of our population of 50 million in the early stages, receiving most of these from the COVAX facility. Of course, we expected at least 24 million doses from the COVAX facility. We have only received 1 million, as I'm telling you, and you know where the problems are, why we're not receiving the rest of the vaccines. We're still in that situation. I heard discussion now, and there has been vibrant discussion around what do we do as developing countries faced with a situation like this. I can tell you that when the pandemic first broke out, and we had the problems with supply chain of simple things such as PPEs, masks, and others, we quickly encouraged our industries and textile industries and manufacturers to repurpose their production and come up with innovative ways in which they can be able to produce these products which they had not done before. And I think they responded very well. We now have a number of local industries that are producing masks, the coveralls, the PPEs, which I think we're even exporting to some countries in the region. So, I mean, that teaches us that if we have a resolve, when we are faced with a challenge, if we put our minds together and put our resources where it matters, we can overcome. And I think when it comes to vaccines as well, I'm very happy to hear that countries like Uganda, Rwanda, South Africa are quite advanced in terms of going down that road of producing their own vaccines, whether it is a fill and finish or whether it is an entire setup that begins from the very early process of development all the way to the product. This is the direction we need to go as Africa. I know that there's vibrant discussion spearheaded by the African Union and the CDC Africa. There are discussions in that area. As in Kenya, we're very keen on that. We are having very high level discussions to see how we can begin something, even if it means beginning with a fill and finish first, but then moving on. However, the fill and finish approach to me is something that I think we need to consider very seriously, because by saying fill and finish, we are making the assumption that the problem is the fill and finish. The problem is not the fill and finish, we know that. The problem is the availability of the product itself along the line. So we need to go down, I think, a little further. We really need to develop the basics that are required for us to get into this biotechnological space where we can be able to produce this. Uganda is talking about producing PCR reagents, the enzymes that are required and all of that. It's a doable thing. It's not very high technology, but it can be done. There is possibility to actually engineer vaccines, test them and develop them and put them out there. Many countries have done it. Many countries with lesser resources than us are doing it. Cuba has about 4 vaccines that they have done. There's no reason why as African countries, if we put our minds to it, if we put our will and resources to it, we can do it. I think that's the direction that we need to go. That's the strong message that we want to send here from Kenya, that we are keen on that area. And we want to work with countries within the region and see how we can together be able to build these capacities. So that is on vaccines. I would like to just highlight some few challenges that we have noted during our response. Funding gap was a big problem. Mobilizing resources, and we had in certain cases to go to the big lenders and get funding to be able to support some of the activities. And we're not talking only about the health aspects of the response, but also the economic aspects and the damage that was done to the economy, the alleviation of the suffering of people as a result of this economic decline.
For the opportunity to talk, I'm now going to give Professor Ibengira.
Okay, I think, yes, I don't want to take a lot of time. I hope that I have touched on some of the key highlight areas, and I'll be available to respond to any particular question that may be addressed on my remarks. Thank you very much, Honorable Minister, Honorable Ministers, and all the...
Mr. Rashid Aman, for sharing with us the Kenyan experience and also encouraging the African countries that we can do it. And we are doing it. Not only are we managing COVID, but we are surviving. And I know for sure that Africa will not be the same after this pandemic. We need to discuss a very important topic, and that is the topic of human resources. And I want to turn to you, Professor Ibengira, as someone who is coming from the training universities. In all the discussions that we have had, you have heard from the health ministers that one of the most important resources is human resources. And we do get challenges with human resources, usually when it comes to clinical care. But with this pandemic, we are also getting challenges with human resources in many other areas, in many other pillars of the pandemic. As somebody coming from a well-known training institution that is recognized internationally, we want you to share with us some of your insights in quick training of human resources. And when I talk about quick, I'm not meaning, the long-term training where you plan for specialists, but we quickly need people with skills to come in and handle the pandemic. And we have had outcries from several other places. Why don't you recruit those who are soon finishing? Why don't you look at those who are, in their third year doing some of the specialist courses? But you do know the challenges with training. When I talk about training, intensivists, surveillance officers, personnel to handle the laboratories. And as you talk about that, also give us some of your insights in what we can do regarding human resources so that we meet one of our targets in the Sustainable Development Goals. Over to you, Professor Ibengira.
All the other ministers who have spoken. I'm not a minister of health, but I come in as one of the panelists from the education for health perspective. So, Honorable Minister, the issue of human resources for health in this, in managing this pandemic has been very crucial, but I would like to say that human resources has been a big challenge, especially in the African countries. And we had a session specifically on human resources for health this morning. I believe most of our listeners participated in that session. And therefore, the challenge for human resources is ongoing, but most of our countries have made whatever is possible to address this challenge. Now, the health sector requires quite a number of cadres to do healthcare and the related services. And therefore, most countries have prescribed the specific categories that they need for health and for rendering equitable health services. And therefore, the health sector should always be prepared for any eventualities and for any epidemics, for any pandemics, meeting emerging and re-emerging epidemics and other diseases which affect the populations. And for that matter, here in Uganda, I think in the for some years now, there has been increased capacity in training human resources for health with the coming in of various medical schools. Right now, we have over 12 public and private medical schools which train the various cadres required in health. And therefore, what it required at this moment was a quick reorientation of the already existing cadres in health to meet the service needs to take care of the COVID-19 pandemic. Of course, I appreciate what our Honorable Minister from Equatorial Guinea has said, that they had to quickly bring in expatriates from Cuba. But I think what we have learned from this pandemic is to be self-reliant and to repurpose and to reorientate our human resource. But otherwise, countries should always be prepared to have the required human resource to meet the needs of the population. We should be in position to build the capacity to ensure that a certain percentage of the population has the required percentage of human resources, be it doctors, be it nurses, be it specialists, be it technicians, and so on and so forth. And therefore here we needed to quickly adjust, and which I think has happened both in the private and public sector components of healthcare in this country. Yes, it has been on the facilities component that we seem to be lacking, but I think as far as human resource, we have really struggled. What was needed is also to orientate them and train them to make sure that they are able to circumvent catching the infection. It's unfortunate that most of we've lost quite a number of healthcare human resources to COVID. And I would like to really condone with Kenyans who have lost quite a number of 40, but even here we have lost some a good number. And Honorable Minister, I think you appreciate the numbers. However, we continue to meet the needs as far as the specialties are concerned. Critical care, intensivists, the clinicians, on nursing side, the nurses, critical care nurses and intensive care nurses, and on the laboratory aspect, the technicians, highly trained technicians at degree and master's level who can handle the requirements of high profile testing like PCR testing and so on and so forth, so that you are able to have a turnaround time in record time for the investigation, for the results, and you are able to launch a strong surveillance mechanism to ensure that you are able to match with how the disease is progressing in the community. So, Honorable Minister, I think as we plan for sustainable preparedness for pandemics, we need to ensure that we have cadre on standby, cadres of health workers who can manage those emergencies, but also who can manage other diseases. Like right now, we are into an epidemic of communicable diseases. We really need those health cadres, healthcare human resource cadres who can correctly manage cases, even up to the district and health center force. And as we talk of universal health coverage, I think this should be part and parcel of that plan to ensure that every part of has accessible, equitable healthcare services for the population. And these have to be run by the necessary human resources, all cadres. You need technicians, you need you need those to manage the diagnostics, you need those to manage the clinics, you need those to do prevention, you need those to do both primary and secondary prevention, you need those to do surveillance, and those to those to manage the IT and information that is involved in all that, and those to maintain the facilities as far as their technology is concerned. So, Honorable Minister, we also require support from other sectors. Let's see, quite a number of sectors: transport, agriculture, water and sanitation, you know, so that you will find that health does not only depend on human resources for health that are specific, but it touches on human resources for other sectors. Honorable Minister, I think I should stop at that, but also quick to mention that annually we need to prescribe the number of or the number of human resources for health that need to be trained, keeping also in mind that there is a big demand for human resources for health on the continent and also in other continents, and there is migration that is continuous. Honorable Minister, I beg to submit at that level.
Thank you very much, Professor Ibingira, for those insights into sustainable human resource development and capacity building. We are now going into a question and answer session. I know there are many people who would like to ask you, Honorable Ministers, questions that you could respond to. Already there are some questions that have come on chat, and I will just go through them so that you could pick them up And one of the questions is to all the ministers, where does the issue of the European Union not recognizing Serum Institute's vaccine leave us? What are your comments about this? And I will leave that to any of the ministers to respond to. And I think this question has been ably answered by Professor Ibingira, the issue of plans for capacity building, protection, and facilitation. But I would also like the Honorable Minister from Equatorial Guinea to talk a little bit about facilitation of health workers, picking from your experience of bringing in doctors from Cuba. How cheap are they during this time of the COVID-19 pandemic? And what happens to your own health workers who are in there managing the pandemic, and they also would like to be facilitated? So I will be asking the questions as they come, but right now we could turn to those two questions and request any of the ministers can respond to the issue of the Serum Institute of India and the European Union's issue on the vaccine. And then perhaps we start with the Honorable Minister from Equatorial Guinea, talking about the experience of facilitating and motivating doctors. Over to you.
Thank you very much. I have to give a background. Our Faculty of Medicine is co-shared by Equatorial Guinea and Cuba. Part of doctors, they start from the 1st to the 5th year, and then they go and do the 6th and 7th year in Cuba. And others, they start in Cuba, they come and finish in Equatorial Guinea. Then 4 years, 2 years in Equatorial Guinea and 2 years in Cuba. So most of our health system contains Cuban doctors and Equatorial Guinean doctors. Now, what happened with the COVID is that we realized that we didn't have enough intensive care personnel management, whether nurses or specialists. In the laboratory, we didn't have enough personnel except those in the high-level laboratory that is actually participating in the development of the malaria vaccine. So when we had the problem, we needed nurses for intensive care. We needed also more doctors for intensive care. So those who came, besides the fact that, of course, they're not free of charge, it's very expensive actually, but they were also using them to train our own doctors to work with them, because we needed shift. When the infection was at the high peak, we needed really a shift of 8 doctors, 8 hours per doctors, a group of 11 or 12 nurses, doctors, and so on. So our own personnel could not cover the 3 shifts that we needed, to the extent that we had to bring in 77 Cuban doctors, because most of our people, they train there. Their colleagues who were in Equatorial Guinea, they trained there. So the communication was much more easier than to go to Spain or to other countries to bring doctors. And then the training aspect of it also, they are being trained. So they're there for sometimes some of them have gone back. But then another problem that we had is that we had infected our health personnel in the first 2-3 months. Although we have been preparing ourselves against Ebola, but then there were Ebola in West Africa in 2015, and we had some training. But then most people, when the pandemic came, they were just going to the patient without protection. So we had infected 65 medical doctors, health personnel, of which 5 medical doctors died, especially gynecologists. They were not taking care. They thought that it was a respiratory problem, So they didn't need to protect themselves when they went to emergency, ignoring that they could be dealing with a woman on labor, but who is positive. So we lost two gynecologists and 3 medical specialists. This is what made us to, for the training, because everybody needed to be trained. Luckily, in the second wave, we had very few infected. About 16 medical doctors were infected, personnel here, I want to say, were infected. So going to Cuba, it doesn't mean that we don't train our own people. It's because of this agreement that we have. And it was much easier for us to work with them, the same type of equipments and so on, and then the training, because most of our doctors have been trained there. So that's why we shifted. But then we have got our own university. We train people, and we also train abroad. We are now, I myself, I'm very much interested in district health system, the strengthening of the district health system. So we are training doctors on primary health care, on public health prevention, and so on. In fact, when it came into vaccination, the vaccination of COVID, we didn't have any problem because we have all the equipment set, including the conservation of vaccine, the maintenance, the equipment, the transport, everything was set, not for COVID, but from the district health system that we're implementing. So that's what I can share with you. Thank you.
Thank you very much, Honorable Minister. That was, I must say, it is the way to go. We need such collaborations because they build our capacity. And indeed, you have thrown great light on the issue of intensivists and also ensuring that our doctors don't get tired. They work in shifts. Not only the doctors, the entire medical professionals, who they need to rest. So we need quite a number to be handling the situation during any pandemic. And we want to congratulate you really for that insight that you have shared with us. So let me turn to Dr. Rashid Aman.
Thank you very much, Honorable Minister.
Yes.
There were 2 questions that you posed. I think I will pick up from where the Honorable Minister from Equatorial Guinea talked about human resources for health, in particular the Cuban doctors. We too had a brigade of Cuban doctors who came to help us during the very early wave of the infection. This is a result of a relationship that we have established, a broader relationship we have established with Cuba, where in 2018, we visited Cuba, looked at their health system, studied their health system, and determined that we had gone there to particularly look at how we were going to address our gaps in especially specialists that we require. We have a huge gap in specialists. And the facts that we know is that, yes, we have local specialists. Our local specialists tend to remain in urban metropolitan areas. They are not willing to go down to where they are needed in some of these far-flung places and in the counties. So there's really been a gap in many of these specialties that we just were not able to fill. And since we were moving on with universal health coverage, we said, let's go and explore what's happening in Cuba. We looked at Cuba, we looked at their system, their focus on primary healthcare, the family medicine model and all of that. And we decided that we could bring in some specialists and distribute them to the counties where there are hardly any specialists. We did that. We brought in 100 doctors, specialists, all of them, and took 2 doctors to every county. Of course, we had an uproar. We had a reaction from our young doctors, the unions, and so on. But we felt that that was necessary to support the counties because the gap exists. It's a real gap. When we're talking about specialists, we're not talking about doctors who have just graduated from medical officers or so on. We are talking about people who have had many, many years of experience in a particular clinical specialty. So I think all that died down. We've now had these doctors for 3 years in the country. We will continue to use them. But the idea really is not to replace our doctors. That would be counter to what government stands for. The idea here is to be able to plug in those gaps temporarily, while at the same time as we work towards building our own capacity. And in that sense, we started a program of training specialists, some of them in Cuba. We actually trained 50 doctors in there who will be graduating very soon, in a few months' time. And we are continuing to explore ways in which we can address this human resource problem, which is common to all of us. How do we train doctors? Part of the big problem is the time it takes, the nature of the specialization of the training, the limited number of facilities where they can do this kind of work. So we are exploring many ways, including using ICT, telemedicine, and many other approaches on how we can improve this. We are developing now a policy along that line, and I hope that that might be useful for some of our neighbors as we move on. So the brigade that we received came to us as an offer, free offer from the Cuban government because of our relationship. They sent us a brigade of 20. They constitute these teams for the COVID response. If you recall, they sent some to Italy and many other places, teams of 20 specialists, intensivists, and so on. So we had them for about 6 months here, and they actually did a good job before they went back. That was a donation. We didn't pay anything for it. So much so for the Cuban issue. I think the big question here is the question about the Serum Institute of India and the statement by the European Union that they do not recognize the product that comes out of Serum Institute of India. To me, I see this not as any real technical problem because the vaccine is an AstraZeneca vaccine. It has already been approved. It's EUA from European Union itself, from World Health Organization and many other regulatory institutions. And it is being used in the very same countries. The only problem here is the site. The fact that it is in a different site and they talk about a dossier, they need some information on that. I think that we will ride over that. I think that the sense will prevail, I hope, and we will continue to be able to use those with confidence because it is the same product, it is protective, it has been determined to be protective. The only problem is that this is one way in which the EU will be able to lock out travelers who have received this vaccine from going to their soils, which again is part of that unfairness which we have been talking about, the capitalism, vaccine capitalism. But I hope that we will be able to prevail on this. I think more noise needs to be made on this. And at any rate, these vaccines are still experimental. The EUA authorization means that we don't have complete information and sets of data on these. So to come up and pick on the fact that it is produced at another site, I think is unreasonable. That's my personal view on that. Thank you, Honorable.
Thank you very much, Dr. Rashid. In any case, the Serum Institute manufactures many, many other vaccines, and we have been using them over the years. And so we shall be waiting to see how that story unfolds. I would like to turn for a few minutes to the Honorable Minister from Zimbabwe, and then I'll get back to Uganda, where I can give opportunity to the two ministers from Uganda to say something. Honorable Minister from Zimbabwe.
Thank you, Honorable. I'll turn to the personnel to do with training and all that, and how to manage COVID. I want to say with our specialists, for example, in Zimbabwe, we managed to get down to the bottom of the problem, because, you know, most of our doctors, be it specialists or general practitioners, nurses, there's massive brain drain in Africa. So I think we need to, first and foremost, Doc, is to manage to train our specialists locally in our own countries, then in Africa itself. Two, we need to really find out what problems make our doctors say refuse to go to counties or districts. And when we discussed with our own specialists, we now have agreed to go to provinces and districts. We found that it's people emigrate or to go to other countries, not really for money only. So we need to look at non-monetary incentives, like accommodation. They need all these things, investments, and even transport for them. Because we have found that, for example, we have managed now to have, at least in our hospitals, we are going to have about 20 different specialists. Our smaller hospitals in districts are going to have about, have about 5 specialists in different fields: anesthesia, obs and gynae, surgery, and pediatrics, and medicine. I think we need really to get and ask their problems. And we also need this COVID time. We need to make sure we protect them. They must be the first ones to be vaccinated. In Zimbabwe, when we got our vaccination program on the gear, they were the first ones to be vaccinated. Of course, there was some resistance here and there, but now we need to really protect them. And those who work in intensive care units need massive protection. We need to up our intensive care units and put up negative pressures to make sure that when these ventilators breathe out the virus, then the medical staff does not breathe in the virus. So we need to up our standards as well to make sure that they are happy and safe by introducing these massive protective mechanisms other than the non-monetary gains that they have. And we need also to make sure that they have the instruments and gadgets that they need to use whenever they are in the districts or in the rural areas, even in towns, so that they are happy to do what they are trained to do. And we need also to be sure that the doctors have proper ideas of where we want to go as a nation ourselves. We need to be clear with our vision as countries and as ministries so that they can be part of it. We also need to make sure that they contribute in the direction that we want to move the nations, and make sure involved in the trainings that we want to do and tell them where we want to go. For instance, if we want to go to Plenary hospitals, they need to be part of the discussions. All the research that we need to do, they need to be part of it and take direction and make sure we support them as our people. To the AstraZeneca and Serum Institute of India, I'm sure it's commonplace that people will always have complaints and doubts whenever something is done in a place that they think is new and that they suspect. I'm sure we all know that if I want to buy something from Uganda to Zimbabwe, people will say, oh, it's from Uganda. We always tend to have doubts about one, ourselves, and our wherever things are made. We are always wanting time to believe places that things come from, especially if it's not the original place. This is quite common. People with time will get used. And I'm sure the vaccines that come from the have been used, and most of the medicines that we are using in Africa and other gadgets are all from India. So I'm sure it's just the talk of the population that is not sure of what's happening, because the COVID-19 was discovered by scientists, and it's scientists who are running around producing these vaccines. So we definitely need more time of awareness and awareness and awareness to make sure people understand where we are going and where we are coming from, because these pandemics are going to be with us and many more will come. These cycles will come. I thank you, Honorable Minister Roth.
Thank you very much, Honorable Minister from Zimbabwe. Allow me now to invite Dr. Musana.
Honorable Minister, I would like to intervene.
Yes,
It is
please.
now 4:04.
Yes.
We can use another 6 minutes to have concluding remarks so that we are in time for the next sessions.
Yes, I do believe the ministers have given their concluding remarks. Let's hear from Dr. Musenero, and then we close. Honorable Musenero, please do come in.
Thank you very much, Honorable, and I greatly appreciate the comments on human resource from the different ministers. Given the structuring of our communities, as we develop the human resource and workforce, it is important that we target the workforce also for prevention of disease. Sometimes we are focused on the therapeutic workforce that is working in the health facilities, and the people keep flowing in and in. So referring to my first comments, like as we talk and as we innovate, especially specifically for Africa, we need to think how we can use the less sophisticated systems. These Western countries have been able to improve quality of care because they have dealt away with so many diseases as a result of community interventions. So if we do not have community health workers, people who prevent unnecessary illness, we will have a hard time building up sufficient workforce, and we'll end up with a very bloated healthcare system within the facilities that we cannot pay very well. So especially at this time of COVID, I strongly believe that if we can boost the community healthcare structures, empower those people, because it's about prevention of infection. If we can strengthen the prevention of infection, I don't know if Professor Ibingira and those training have come up with something that trains these community health workers at sub-counties, those public health officers. They do a big lot of work. If they are skilled, then we will only have the manageable number of cases. The second thing I want to comment about is to appreciate the importation of the bringing in of experts. Whereas we may have a lot of young people within the country, developing consultants and experts takes a long time. I want to propose that African countries, we should have a policy developed where when we are attacked, we can recall our experts to come into the country and give seniority to our local staff, because like right now in previous epidemics, we have a lot of external people with us, but in this time we don't have. But we are our own experts. Uganda is known for being the source of the best epidemiologists on this country to design community interventions. We do not have many of them in the country. Yet when they were here, they would be able to disciple the young ones so that they can have that seniority. They can also improve their skills. So can we be able to build where we can, when we need to recall our experts from wherever they are scattered in the world to come and give support to African countries? Thank you very much.
Thank you very much. Allow me, honorable ministers, to appreciate you for the great input. Definitely the issue of strengthening community interventions is extremely important because we need to prevent, and prevention is the cheapest vaccine that does not need resources. I also want to thank you for sharing some of what you are doing in your countries. Definitely it has been a great learning experience from each and every one of you. We do appreciate you. Thank you very much for visiting Uganda. I hope you do find time to move around a little bit and see some of the areas where you are staying while keeping safe. It has been great for me coordinating and chairing this meeting. We will now turn off since you have other sessions to chair. Thank you very much and kwaheri. Bye-bye.